Good evening and welcome. My name is Julian Perez, and I am the Vice President of Risk Management and Regulatory Compliance for dentalcorp. I am joined today by a guest that I'm very honored and excited to speak with for the next 45 minutes or so. Today we'll be talking with Dr. Gary Glassman. He is dentalcorp's Chief Dental Officer. He facilitates the company's continual growth ambitions, and he champions programs to support the practice community in the delivery of optimal patient care. He's a world-renowned endodontist. He's an accomplished speaker and lecturer. He provides dental education not only in Canada, but throughout North America and throughout the world. Gary's also a fantastic colleague to work with. In full disclosure, he is part of the company that I work with, and he's just a brilliant mind, somebody who's very generous with his time and his knowledge, and I'm thankful that he's here today to speak with us and share his experience as far as it relates to COVID-19 and the dental world, and how it's changed over the past couple of weeks. So Gary, thank you so much for your time. Really appreciate you being here this evening. And I'd like to get right into it.
Okay, nice to be here, Julian.
So this is our first session where I'm not in the same room with the expert that I'm interviewing. It's a sign of the times. We're all doing our part now to practice social distancing, to minimize the encounters that we have with other people, to stay at home. Today, our city, Toronto, declared a state of emergency. Our province is already under a state of emergency. The federal government has taken a number of extreme measures, including closing the borders, restricting access to the country. So these are the times that we're in. We are in the middle of a global pandemic, something that nobody alive has really experienced, at least not the way we've reacted to it. And it's impacted every aspect of our life. It's certainly impacted the way we practice dentistry and the way we support those who practice. So my first question, Dr. Glassman, is just going to be, how has your practice changed over the past couple of weeks?
Julian, it's a great question. I mean, it's changing minute by minute. As things change in the world, so does our practice. With respect to screening patients, the screening becomes more firm with our patients. We want to identify those patients that have true emergencies, and those true emergencies in the dental world are uncontrolled pain and infections that prevents them from working, most importantly, sleeping, and interferes with their day-to-day living. And when we identify those patients that have true emergencies, we're very, very strict with our screening as well with respect to COVID-19. Do you have fever? Do you have sore throat? Are you feeling unwell? All these things are so important right now, and these screening measures are so important so we can identify those patients that perhaps we can treat with medications over the phone and communicate with their pharmacist, or whether they are true emergencies and they have to see us in the office to relieve them of their pain and or swelling.
So it sounds like there's been a number of changes, and I think we'll get back to many of the things you just touched on during our conversation. But before we do, since I've asked about the past, before we get to the present, I'm going to ask you to look into your crystal ball and tell me, where do you think we'll be in a week? Can you tell at this point what dentistry and what your specialty will look like in a week?
I've given up trying to predict the future, Julian. I think, as I said, everything changes minute to minute. So where we are now will change definitely, and probably be a little more firm in all our screening procedures and the way we conduct our business in the dental office.
So in terms of screening, then I think that's a really important aspect of what dentistry is right now. Usually it's get the patients in, talk to the patients, treat the patients. Right now, a big part of what we're doing is that magic word screening. So the RCDSO in Ontario, the dental regulator here, as well as regulators across the country, have advised dentists that they should screen patients telephonically. So the clear guidance is that any patient who can be rescheduled for a few weeks or months down the road should be rescheduled. So in the context of an endodontic practice like yours, what does that look like, and what does that mean to you?
Same guidelines, but with respect to the criteria, what you have to understand is as an endodontic practice, we are an emergency practice. We see patients in pain. And we have two main endodontic emergencies. One is that irreversible pulpitis with apical periodontitis, where the patient comes in, they have hot and cold sensitivity. It may be pain that doesn't go away, that's spontaneous, that won't be relieved by anti-inflammatories, which we will touch on shortly. Which only can be relieved by actually going into the tooth and removing the dental pulp. Second main dental endodontic emergency is a patient that presents with an acute alveolar abscess with or without swelling, where it's a non-vital tooth. Patient has incredible pain, possibly with swelling, possibly without, and we have to make a judgment call. Do we prescribe them antibiotics? Do we have to bring them in and drain it through the tooth and or through the soft tissue? Which brings us to another discussion that we're going to have with respect to medications that we may have to prescribe that normally in a normal world we may not have.
Bunch of interesting points there, and certainly a lot of threads to follow up on. So let's first, pain and infection. Those are two words that are really critical to the definition of dental emergency. So I'm just going to read what the RCDSO put out most recently, actually today, in their statement. It's short, so I'm going to ask you to unpack it a little bit from your perspective and with your expertise. It says, in dentistry, a true emergency situation includes orofacial trauma, significant infection, prolonged bleeding or pain, which cannot be managed over-the-counter medications. So there's two parts there that I think are relatively pertinent to your world. One is significant infection, and the other is pain, which cannot be managed by over-the-counter medications. So it's a two-part question. The first part is, with an infection, how do you determine if it's significant and is indeed an emergency that you should be treating at your office?
Great question. With respect to infection, the patient has swelling. It depends on the level of swelling. It's something that we can control by antibiotics. Then certainly we live in a world right now where we're trying not to bring the patient in. So prescribing them an antibiotic, a wide spectrum antibiotic such as amoxicillin, if they're not allergic to it, obviously, they have no adverse effects to it previously in their history, then prescribing them that and seeing if things resolve within 24 to 72 hours and keeping in constant communication with the patient. We give our patients our cell number to text us at a moment's notice. We will respond to them. If, of course, it's getting worse and they develop a space infection and we feel in our judgment that's what's happening, then the emergency room of the hospital may be the best place for them with respect to that.
And in terms of in terms of infections, we'll stick with that and we'll get to pain in a minute. Have there been any instances recently where a patient called in and described symptoms to you that you felt were an significant infection that required a referral to the ER, or have you been able to manage all of these things either on the phone or by providing endodontic therapy?
Yeah, most of the time antibiotics have been working. I've had to bring some patients in where I've had to drain through the tooth and or through the soft tissue. But most recently, last night, I had a patient who we recommended treatment many, many months ago, and she's just stalled the treatment. She had an infection around a tooth. We recommended retreatment, of course, also the option of extraction. She did neither. She called in a panic. What do I do? My eye is closing. I have a fever. I have the chills. This is the type of situation where we're not going to manage in our office. We're going to make a call to the emergency department. One of three, Mount Sinai is the one we chose. Sunnybrook also is available, and Sick Kids is one of the other three that are available in the GTA. We made a call to them. They were expecting her. Amazingly enough, Julian, she arrived and she sent me pictures. The emergency room was completely empty.
That's amazing, because I think everybody right now has this image in their heads of hospitals that are busting at the seams. Do you have any theories about was it the time of day she was there, or is there any theories about why the hospital may have been so deserted?
It was at night. It was probably around 10 o'clock at night where a lot of emergencies would come. And I imagine, and I only hope and I pray that people are practicing social distancing. And by doing that, maybe they have less falls, maybe they have less trauma, maybe they have less need to actually be in the emergency department of these hospitals. And therefore, they're less busy. I'm hoping.
Well, maybe there's a silver lining, and so I think it's important these days where we're seeing numbers of COVID positive patients and deaths. Unfortunately, I think it is maybe a silver lining there that some of the usual accidents and injuries and traumas are on the decline. So I think that was a very helpful discussion about what significant infection means, both in the context of how do you determine if it's an emergency that you'll treat at your office, as well as how do you determine if this is the kind of emergency situation that's better left to a hospital emergency department or a hospital dental clinic. So the other part of the definition of dental emergency that the dental regulators have been publishing recently is prolonged pain, which cannot be managed by over-the-counter medications. So I can only assume that the majority of patients that are looking to be treated at your office, at an endodontic specialist office, are in some sort of pain. How do you query whether that pain is prolonged and cannot be managed by over-the-counter medications?
Yeah, that's a great question. It comes back to infection as well, because a lot of times the pain is related to the infection
Mhm.
and vice versa. So we're a little more firm with respect to querying on the pain level and how much pain do you actually have? Well, I've had it for, a few weeks. When I touch the tooth, it hurts, but if I don't touch it, I'm fine. As opposed to I can't sleep at night, I can't think, and it's affecting my day-to-day living. And that would be a situation where we need to get them in and prescribe some sort of treatment in the office and/or give them some sort of pain medication. If I could go back for a moment with
Sure.
the antibiotic piece as well. Typically, standard of practice, if a patient comes in with an acute alveolar abscess and we diagnose that, typically standard of practice is to open up through the tooth, as I mentioned, and or through the soft tissue, and only prescribe antibiotics if they have fever, malaise, lymphadenopathy, immunocompromised patients. And typically that's where we would only prescribe antibiotics. The times are changing, and the risk benefit ratio has to be looked at with respect to, are we going to prescribe the antibiotics, and knowing the risks of possible upsetting the gut biome, superinfections, resistance, allergic response, adverse reactions, and balance that with the possibility of having this infection get out of control. I think we have to change our way of thinking for now until we get this under control.
Well, yeah, and I think doctors are always struggling with that balance of you always want your treatments to provide more benefit than harm caused. With regards to the risks that patients are taking simply by leaving their house, going to a dental office, sitting in a chair, having a dental procedure, have you thought about including any of that into like an informed consent discussion or conversation that you're having with patients?
Of course, in order to minimize that problem of community transmission,
Hmm.
when we have patients come into the office, we have them come in at one at a time. If they are accompanied by family or friends, we ask them to wait in the car, unless, of course, they're a situation where they have to be accompanied by someone if they're incapable of traveling on their own. In our own office, we are down to a skeleton staff. We're minimizing doctors, we're minimizing front desk staff, admin, we're minimizing assistants. We're keeping only those essential staff that we require for the best possible treatment that we can, and minimize that patient-to-patient transmission.
So we're talking about that, about controlling the infection and preventing the infection. I thought we might get into one of the hot topics in infection prevention control right now, which is what is the appropriate personal protective equipment that doctors and dental assistants should be using during procedures. So again, this is something that is changing very rapidly. I think you used the word minute to minute, and it wasn't much of an exaggeration at the top of this interview. So again, the RCDSO has clearly been following this and clearly concerned with the health of not only patients but the public in general. And today they issued a new guidance on true emergency situations. And this one, unlike the previous documents we've seen, doesn't seem to focus very much on screening for symptoms of COVID. I don't know if you were able to read through the guidance, but did you notice that? And do you have any sort of theory on what might be
Yeah,
behind that?
I've read them over and over again, and there's another page that was missing, but what's conspicuously missing is exactly what you said, is the COVID piece. So what it means to me with respect to the guidelines is if we are going to treat patients, we have to assume that they are COVID-19 positive.
Yeah, that we're in this community transmission period, the not only do we have to assume, I guess people could have gotten it at the supermarket. They don't have to have come back from vacation in Italy anymore to come down with it. I guess we just have to assume that the person in your chair could potentially spread it to you or your dental assistant, and you have to be very careful. So, in terms of really what it focuses on now are two different kinds of procedures. One that create aerosols and procedures that don't create aerosols. Maybe you can talk a little bit about that dynamic in an endodontic office. Are there different sets of PPE that you might be wearing depending on what you're doing?
Yeah, so if we're going to be doing a consult only, and we're not going to be doing any treatment, level 3 masks that we're also used to, gloves, eye protection would be necessary. If we're going to be treating the patient, no matter what, if there's an aerosol or not, um, I think we should take those precautions of a fitted N95 mask, and that's key. A fitted one, properly fitted, rather than just slapping one on and hope that it protects you and or your patient. Barriers, gloves, masks, of course, those N95s that are fitted, the gowns. I'm even thinking about, even though it's not in the guidelines, head covers and even shoe covers as well. Take it to the next level. And I think what's going to happen, Julian, I think this is going to take universal precautions that we've been practicing for decades based on the old way of thinking, and it's going to be universal precautions to the next level moving forward, even when all this has died down and the smoke is cleared and we body slam this virus away.
And is that a good thing?
I think it may be a good thing. I think what's going to happen is people are going to be more aware. They're going to be more cognizant of what they're doing, how they're doing it. And I think in the long run, it's going to be better for the patient and better for the community at large.
I certainly hope that's the case. So, I'd like to um, transfer to another topic of conversation now. Uh, as a result of a lot of the provincial, federal, and regulatory guidelines that have come out, a lot of dentists are working less than they have probably in a long time. And there are a lot of dentists out there who, even though they're following the minute-by-minute guidelines, may have seen their day-to-day slow down a little bit. So, people who are providing care that might not meet the definition of emergencies, people who are doing cosmetic treatment, certain specialties like, even orthodontics. What would you recommend to your colleagues, your friends, to dentists out there who all of a sudden have free time on their hands? How should they be handling the situation?
Well, it's a great question because there's going to be a lot of free time going on with docs and staff, etc. Closely monitoring the situation is important. Good communication with your patients. Make sure that your websites are updated and you have the latest of guidelines on the websites. Make sure that your patients have access to you and you're available to your patients. That's most important. That being said, once all those basic things are done, then it's probably a great time to, start communicating with your family again. You know, social distancing doesn't mean social disconnecting.
Mhm.
it's a great opportunity for families to reconnect, to actually sit down and have dinner together and watch movies together. Hey, there's a whole Netflix library that's just waiting to be watched by everyone that we never have time to do. Getting down and sitting down and playing games for the doctors and the staff alike. There's a lot of CE that's available, so you have that opportunity to go online. There's a ton of courses that are available. I'm faculty chair for DC Institute, and DC Institute is offering a bunch of online programs for everyone to log into and get your CE points and just further your knowledge, because this is a great opportunity to do that. Stay ahead of the curve and just get as much knowledge as you possibly can.
So there's a whole bunch of things, which is really exciting. I read an article earlier today that was entitled "The Telephone Call is Back," and I laughed because I had just gotten off the phone with my mom, my dad, my brother. I'm American, so I have a lot of relatives who live quite far away. And again, in terms of silver linings, I think people are getting in touch with some of their loved ones or some of the friends maybe they haven't spoken to in a long time. And certainly CE is obviously, you want to make the most out of this and stay current. So I think that's great advice. So I'm going to bring the conversation back to the beginning when we started talking about screening patients. Again, a number of the regulatory bodies have said that all patients must be screened by the doctor telephonically. So for a specialist, it's a two-part question. So I'd just like to ask, is that something you're doing yourself, or generally is it the general dentist who's referring a patient to you who's already screened that patient?
I would hope that the general dentist is screening the patient, but a lot of patients just come to us directly. Either they've been to us for treatment before, they know of us, they Google us. We know we're an endodontic office, they may need root canal treatment, and some are actually coming from their dentists, or dentists are calling us directly, can you see my patient? So we ask them, can you please pre-screen your patient? But we will be pre-screening them anyways to the standards that are possible.
So, if you're whether you're pre-screening or the general dentist is pre-screening, I don't think there's ever been so many dentists on the phone with their patients having sort of elaborate, detailed conversations. The default previously would be, well, it certainly sounds like you have a dental issue. Let's get you in. Today, I think there's a lot more expectation to see, can it be managed? Can it be controlled? Can it be addressed with medication, with consultation? And a lot of, there's been news about U.S. senators buying stock in telehealth companies. What do you think about the current state of teledentistry? Is this something that you've had any experience with? And, if so, what do you think dentists can do to try to meet the regulators' objectives?
Yeah, I think this is the wave of the present and the wave of the future with respect to telehealth, teledentistry. I think whatever we can do, and if we can treat the patients remotely, especially in these times, that would be the best way to do it, especially with screening and being able to prescribe the proper medication. There are many telehealth platforms which are excellent, but sooner than later, we're going to find some amazing teledentistry platforms that are going to come our way, and we're going to just capitalize on that in order to provide our patients with the best possible care that we can do remotely.
Well, I feel like we could talk forever, but I know you've had an extremely long day. I've had an extremely long day. Um, just want to know if there's anything else you'd like to just sort of mention to people before we wrap things up and move on to, you know, life as it is under COVID-19.
I think number one, we all need to remain calm, because when calm heads prevail, then we make more rational decisions and we can provide our patients with the best quality treatment possible. I think that in these changing times, we need to improvise, we need to adapt, and we need to overcome this. And I think if we all work together, we can, and we'll be stronger and we'll be better for it.
Well, and I think that's That's a great message to end on. So I just want to say one more time that it was a total pleasure speaking with you. I wish we could have been in the same space, but it's important also to demonstrate how important it is for us to practice self isolation, social distancing. I know that when this is over, we'll get together and continue working together. And would you be interested if we get questions from people who are tuning in today we could send them to you and perhaps you can answer some of them either in writing or we can follow up the Q&A for those questions we didn't get to ask.
100%. Always
All right.
available.
Well, that's it. Dr. Glassman, an absolute pleasure. I think this is a very helpful conversation. Perhaps we can make this a series and do it again. For all of you who tuned in, thank you so much for joining us. We hope that we answered some of your questions. Dr. G has been generous and offered to continue to answer some of your questions. So if you have any, please email them to us or to the email that you got when you RSVP'd for this. Once again, this is Julian Perez signing off on behalf of dentalcorp. Have a great evening. Stay safe, stay healthy, practice social distancing, be with your families, and we'll all get through this together. Take care.
Have a great night, everybody.